right, so good afternoon, everyone, and welcome back to the Brainy Boomer Lecture Series. We're so very happy that you've all joined us today. In 2007, the McGill University Research Center for Studies in Aging, or the MCSH Education Committee, started the Brainy Boomer Lecture Series in order to suggest practical steps to both improve and maintain brain health, as well as to promote healthy lifestyle choices amongst the most populous generation in history. The MCSH Education Committee, which was founded in 1996, has three main objectives: identifying education needs of healthcare providers, seniors, caregivers, and the public, and to develop responses to meet some of those needs; to enhance the positive image of the aging process by addressing stereotypes and myths about aging; and finally, the dissemination of research on aging. Dr. Dolly Destor is a clinical psychologist specializing in the assessment of dementia. She is an assistant professor in psychiatry at McGill University and chair of the Education Committee of the McGill University Research Center for Studies in Aging. Before coming to Canada in 1973, Dr. Destor was a senior research fellow with the World Health Organization at the University of Ibadan in Nigeria. In Canada, she joined the Douglas Hospital in their geriatric services and developed the program in dementia with psychiatric comorbidity, and was a clinical administrator and co-director from 1998 till 2013. She has published extensively on dementia and caregiving. Dr. Destor was the founding president of the Alzheimer's Society of Montreal and vice president of the Alzheimer's Society of Canada. Before continuing, we would just like to remind you to please mute your microphones on Zoom, and that if you have any questions, please wait until the end of the conference, or you could write them down in the chat box on Zoom. And now I'd like to invite Dr. Destor to start her presentation, Caring for the Caregiver.
Good morning, everybody. I think this is a subject which is very close to everybody's heart because we are all caregivers. And we've been caregivers for our children. We got caregivers when they are small, like when they grow up. We're caregivers for our parents, maybe not when they are ill, but they're frail. So we are all the time caregiving. And most of the time caregiving is something which we do naturally. It's something for women especially. It's like a joy to do caregiving for people. But caregiving becomes a little bit more difficult when the chore itself, when the act of caregiving is more difficult. So today we're going to talk about caregivers and caring for ourselves, because how difficult it is and how can we have to care for ourselves so that we care for the others in a better frame of mind. So we start by saying that who are the caregivers? There are informal caregivers like family members like ourselves and our friends who help us. And there are formal caregivers who are paid caregivers who are working either in Centre d'accueil or coming as private caregivers in our homes. And who do they care for, and why do we provide care? That's another aspect. And the scope of the problem, how difficult or how easy is it, or is it the intensity of difficulty varies from the range of the problem. And what do we need to know to protect ourselves from burnout? And finally, we talk of stress management. So who are the caregivers? In 2011, the first baby boomers reached their 65th birthday. By 2020, and 65 and older, who will have a significant impact on the healthcare system in North America. We will be much more people to look after, much more people in the world. In 2008, there were 103,700 new dementia cases per year. That is one new case per minute. And that's a lot of people with dementia who need care. In 2038, which is not too far away, there will be 257,800 new dementia cases per year, which is much more than what we have at the present time. So we have to think about the future as to who is going to provide care, and if we are going to provide care, how are we going to manage this? So who is providing care? Individuals receiving care in long-term care facilities like nursing homes need care. Individuals living at home and receiving community care where the CLSC sends people in. Individuals living at home and receiving no paid formal care is provided by the family members themselves. And the demand for the long-term care beds is expected to grow. is exponentially. You can see the figures from 2008 to 2038. There's such a big jump, and there'll be a shortfall of beds in the long-term cares. And this will be offset if there's no beds in the long-term care. We have to provide care for our people in the home. Now, what I'm talking of today is much more amplified by the COVID happening now, because there's shortage of nursing staffs, there are people in the nursing homes requiring more care. And so this is all compounded. People are bringing their loved ones home from the nursing homes or long-term cares because they are afraid that they'll correct COVID. Okay, now if we talk about the family care providers, about 10 million people in North America are providing unpaid care for persons living with dementia. And they're all primarily family members and friends. In 2008, Canadians provided 231 million hours of unpaid care, which will triple by 2038, reaching about 756 million hours. That means a lot of economic problems for the community and the government, less taxes if people have to give up their works, people cannot go back to their jobs. That causes all sorts of problems with people themselves. And so that if they're not happy in themselves, they're not able to do well for themselves, they cannot give proper care to the people. So there's a big impact of having unpaid care by the family members. Over the next 30 years, dementia cost to society will be over billions. I can't see my slide. $1 billion in healthcare. The unpaid care opportunities cost, which is indirect cost associated with unpaid care and the paid care. Today in Canada, the cost of caring for one patient at home is $32,865. That is what it costs the CLSC and the government if they're going to send people at home. Or if you are going to provide care, this is what it will cost in the unpaid care, in the hours which are lost, which you have to stop working, or you have to go part-time job or do whatever. So how much care do we have to provide? Some caregivers have to provide 24 hours, 7 days a week, getting up early in the morning, assisting with all activities of daily living, starting with giving them the morning breakfast, giving them a bath, doing all sorts of things. And such round-the-clock care is needed when the person cannot do anything for themselves and they're quite helpless. Now, you have to remember that this care, the amount of care which I'm talking about, is not uniform throughout the illness. In the early stages of the disease, it's much easier. In the middle stages, it becomes more difficult. And in the last stages, it's much more difficult because it requires physical care to help people. In the early stages, it's more emotional care because the person keeps repeating things, they're wanting to demand things, they have resistance. So there's a different types of cares throughout this whole spectrum of the disease. So 32% provide care for about 5 years in the early stages, maybe. Then as the disease progresses, 39% provide about 1 to 4 years of care. And the caregivers' age range from 14% are under 35 years of age, 26% between 35. Also in generation, you may be looking after your children or your grandchildren, and you have to look after your parents. Your parents and that requires mostly the spouses is this age, and the spouse themselves is older. So the person who's 65 maybe have to give care to somebody, the husband who may be 70 or 75, or the husband may have to give care to his wife. And the average age is about 51. And that's the sandwich generation, which we call, because the person themselves is looking after two different ends of the person, the younger people as well as the older people. And most people in their 70s are looking after people in their 90s. So that's a big chunk. We have to think a lot about the government, and the social services has to think a lot about how we are going to manage as people get older and people are living longer and the diseases are going further. Some facts of Canada, which you must heard because you're attending these lectures often. 2013, and the cost of direct and indirect care in 2013 was 33 billion, and in 2040, the cost is going to skyrocket to 293 billion. I can't even imagine what that figure is going to be like. And in 2013, the family caregivers spent 444 million unpaid hours. In 24 caregivers. 72% of Alzheimer's disease and 62% of all dementia cases are women. So the caregivers and the care receivers are women. Now, people always ask, oh, what is the difference? And this is a slide which may not be really pertinent to caregiving, but it is important for you to know what is the difference between a dementia and Alzheimer's disease. People normally say, oh, my mother has dementia. She doesn't have Alzheimer's disease, or the reverse. The dementia is an umbrella term under which we have several types of dementias. There are about 65 different types of dementias, and Alzheimer's disease is just one of them, and it is the leading form of dementia and accounts for about 50 to 75% of cases. Vascular dementia is the second most, between 20 to 30%, and where there's a vascular problem, the blood flow problem in the brain. And the other dementias are Lewy body dementia, frontal temporal dementia, which is also Pick's dementia, alcoholic dementia, which are not as common as Alzheimer's and vascular dementia, but they are there. So you have to be careful as to know which type of dementia. You have to ask your doctor as to what is the dementia, what diagnosis is it, a specific diagnosis you're giving to my loved one because of dementia. But the common feature of all of them is memory loss. Though, as I said, though age is an important factor, that it usually affects people over the age of 65, but it can affect people between the ages of 40 and 50 years of old. There are some people in their 90s with perfect good memory. Only yesterday, I was listening to a radio program on CBC where this lady was talking. I think she was one of the members of parliament once, who was saying that she was about 40 years old and her husband about 55, and he was developed early on Alzheimer's disease, early onset. And the care for him was so much difficult because the early onset people have not only memory loss, but they have also difficulty in language and difficulty day-to-day tasks. And they are more important than that is they have behavioral problems. They become very resistant. The care for them becomes much more difficult to manage. So people with dementia not only have memory problems, but they also have other medical problems which may require care and which is more difficult. Either take them often to the medical appointments or get them lab tests done, where the person you're giving care to may be resistant to it also. So it requires extra effort on your part. Caregivers of people with dementia provide more help than for caregivers with other older people. If you're looking after your parents who are healthy, relatively healthy, but they're mobile and they become that difficult to give. It's a chore, but it's not that difficult. Whereas somebody who's always resistant to what you're saying, always negative to what you're asking them to do, becoming very stiff and not cooperating, then the care becomes very difficult. And as the disease worsens, as I've said, because the Alzheimer's disease goes from a mild stage to a middle stage to a very severe stage. And as the disease becomes more and more severe, the number of hours that you have to give in and the physical care for the giving becomes very demanding. You have to physically lift up a person from the chair, physically take them for a bath, physically do things. Whereas if they were more cooperative, if they got up by themselves and went to the toilet or bathroom and you just stood there and looked and supervised them, that would be another story. But to give physical health is much more difficult. And in addition to that, you have the behavioral challenges, which I've talked about, and which are more demanding. Afraid to put them away because, or go to somewhere with you because you may get lost if they don't follow you. They may have violent outbursts. There is insomnia, which is much more, it is a one of the signs which triggers you to say that I can't do it anymore. If you cannot have a full 8 hours of sleep, if you cannot sleep well, if you do not feel rested when you get up in the morning, you are not able to give the good same type of care which you're supposed to give throughout the day. So violent outbursts, wandering, insomnia, poor sleep, incontinent, if you have to keep changing them so many times a day, and then if you want to put the diapers on them, they refuse. They shred the diapers, take the diapers out. They will not wear the diapers because they feel it's beneath the dignity. And we can understand that, but there is no other solution at the moment. Then their hallucinations, they think that other people are in their home. They become paranoid. They think that somebody is following them, somebody is looking after them. The person they see in the mirror is not themselves, they're somebody else. And they become suspicious that there's another woman in the house, another man in the house, and they become resistant to care. They say no, no, no to everything you ask them. And more important, they become paranoid. They put their things away somewhere and they cannot find it. And then they say somebody's come and robbed them. And the most person who think they often rob is yourself or somebody very close to them. Caregivers see their loved ones fade away, both mentally and physically. So the caregiver becomes slowly more and more depressed, feels more, should I say, alone, that nobody's there and they're alone to look after this person. If there's some sort of social support, the caregiver feels supported, but the caregiver feels loved one is faded away. The person they knew, the person they loved is no longer there. Both mentally they're not there and physically they're not there. So what are the different caregiving tasks which we do? We have to shop for them, prepare me. If we are living together in the same house, we have to prepare meals and we may have to provide transportation. We have to help with medications, follow treatments recommended, and manage the financial and legal affairs. That's another story, because if the person has not made some provisions in that, they may not have made their will, they may not have made a mandate, they may not have made other legal provisions for themselves, then you have to start the caregiving process, that there is a will there, there's a mandate there, and everything is in order. Supervision to avoid unsafe activities, that's another task. People are getting wandering or they get lost. So it's better to inform your neighbors and your other surrounding people that this is happening. People tend to keep themselves very quiet. They don't want to inform anybody of what's happening. So when a person gets lost, you don't know where to turn to. Or if your neighbor sees your loved one on the road and knows that this is Mr. or Mrs. So-and-so belongs to that house, they may try and bring that person back home. But if not, the person will just keep walking and walking and walking and end up somewhere and nobody knows where the person is, and you keep searching then and the police is called. Then managing arrangements for medical care and paid in-home assistance. There comes a time when you say that, okay, I need some assistance. I can't do it all alone. So let me hire somebody to do something. Let me hire somebody to come in the morning to give a bath or give us some meals or give me some relief or do some housework for me, whilst I'm doing something else. So you have to think about those things and manage. But managing behavioral symptoms in the middle stages. I said that the behaviors and the symptoms are not the same throughout the history of the illness. As it progresses from the mild stage where there's just little memory loss, to the middle stage where there's more memory loss, but together with this more memory loss, you have more behavioral changes. As we mentioned, there'll be more wandering, abusive languages, insulting, swearing, not cooperating. Those are the more behavioral changes. Bathing, dressing, feeding, helping them to the toilet, managing incontinence in the later stages, all those are more caregiving activities which require more physical effort on your part. And if you yourself are frail, or you are having back problems, or you are having other problems in yourself, you're having high blood pressure, or you have diabetes, so you're not in perfect health yourself, then all this becomes much more difficult and you have to think of yourself first. So what are the pressures of caregiving? So when you see all these pressures building up, more caregiving, you have to do more physical care, you have to think of all the things in the future, you have to do some shopping, you have to get the medication in order. So what are the pressures which build up in yourselves? The rate of depression becomes higher. You become more and more lonely. If you have a family which is supportive, if they give you relief, if your brothers or sisters or your children or the grandchildren sometimes come and give relief and say, okay, you take a day off today, I'll stay with grandma or I'll stay with mother, and you take a day off and do whatever you have to do. Just go and sleep if you want to sleep. So those, if you have that sort of a support system, then your rate of depression is lower. Otherwise, you feel all alone. So the depression increases, suicide rate increases, physical illness increases, and there may be premature death in the caregiver, which is higher than in the general population. I had a case a couple of days ago when this lady, she was in her middle age, I think 40 or 45 years old, who used to look after her mother who had cancer. And she died. When she came to us, the mother had just died. But she also had two other sisters, one who had Down syndrome, and the other one who was quite schizophrenic. And she was not extremely uncooperative, any sort of care she would give. So she was completely sandwiched between everything. And so her stress level was very, very high. And she herself was collapsing when she came to us for help. Fortunately, we were able to give her some help. So these stresses increases the high levels of hormones in your body, which are the stress levels. And when your stress level is high, what happens? Your blood pressure rises, your glucose sugar rises. So yourself, your body has, stability is not there anymore. And you more susceptible to other illnesses. There's a more risk of hypertension, heart disease, and there's also if your mother or your grandma or your in-laws is staying with you in the same house as with you and your husband, there's also a strain in the family, strain in the marriage. And so because this is, you're not giving enough attention to me, you're always with your mother, you're always with your father. So this is a strain in the marriage, and 1 in 4 or maybe ends up in divorce. Now, the relationship between the caregiver and the care receiver is very elastic, up to a point. You love the person to whom you're giving care, and you want to give the care, and you feel guilty if you're not doing your best. So there is this guilt feeling in you too, but this relationship is strained. If you always had a good relationship with the person you were giving care, the person receiving the care was a very loving person, very nice person with you, you are willingly giving it, but this relationship becomes strained and strained and strained, and it becomes very taut, and after some time it breaks. And the first thing it is affected when it breaks is your own peace of mind. And you have to be careful as to when you feel in yourself that you can't take this anymore. So when you feel there is a stress in your house, in your body, the cortisol and the adrenal, they rise. And when they rise, your body does not function as it should. Now, there are two types of stress. It's necessary because you need some stress to be able to function, to be able to give a talk today or go for a seminar or do whatever. You need some stress to be able to function, for your adrenal to keep going. If you see a danger and the stress level has to go up, but as soon as that thing is finished, your stress level comes down and your homeostasis comes down to normal. But there is what we call as chronic stress, which means that even the stress does not disappear. The stress in the environment, the physical stress or the environmental stress does not go away. It is continuous, as when you're giving care to a person with dementia who's all the time there's an stress level in your body, and you need chronic stress. So how do you express how do you know that you're stressed out? You may have physical symptoms, which may be like a headache, or you feel loss of appetite, you don't feel like eating, you can't sleep very well, you're all the time tired. Now that's a physical expression. Then there's always also a mental expression, which means you cannot remember very well, you cannot concentrate very well, you have inability to make decisions. The very good example of this is when you are doing an exam. When we were younger and doing exam, when we were all under this high pressure stress, you could not remember certain things, or you're going for an interview and you could not remember to answer the right questions. So that is the mental stress. When you came out of the situation, it was gone. So that stress was an acute stress. But if this stress continues, your memory gets impaired more and more, and you cannot concentrate very well. The other type is an emotional stress. You feel very tense. You feel nervous. You feel frustrated, depressed, and anxious. These are all the emotions you can feel even without stress. But with chronic stress, you feel this on a continuous level, and there's no relief from them. You feel tense all the time, unless when you're really sleeping. And the behavioral, you manifest this in your behavior if you cannot control it any other way. People start smoking. Sometimes people start drinking. People start overeating and put on weight. I said you can have even loss of appetite, or you can overeat, and you bite your nails. You swear. All these other behavior problems keep coming up, which you see in your loved ones. You start reflecting in yourself. So how do we manage this stress? If we've always learned in our lives how to cope with stress better when we were younger, become more self-aware, know how to, know your own strength, and be elastic, be able to react to some things, then we are resilient. We're trying to look to the problem which is in front of you and deal with it head on. But if we are brittle, if we cannot control it, and if your blood pressure keeps rising, your vision and hearing keeps deteriorating, your immune system strength keeps dropping, then you are brittle. You have not learned how to deal with stress, how to deal with the situation in front of you. And this stress then impacts your performance and your ability to be satisfied with life. You're continuously saying, why me? Why am I going through all this? Why does it not affect other people? So you're all the time concentrating on yourself rather than concentrating away from yourself. So now I want to give you 10 simple signs of caregiving stress, so that you are aware of this is happening and you take action in the early stages, so that it doesn't go to a stage where your own health deteriorates. When you keep denying that, no, there's no problem, everything is fine, I can manage. The second one, I mean, these are not in order. These can be any one giving state. And you're a human being, and you get so angry, you may sometimes shake the person up, or you may even slap the person up or hit the person, and then you feel so guilty that you've done this, which you shouldn't have done, but you do it. You don't have to bother yourself with it for doing that. Then you withdraw socially. People ask you to come to their house to kind of have dinner with them or go out for something. You say, no, I can't do it. I'm completely fed up. I just can't do anything. You become very anxious. You become depressed. We told you that. You feel exhausted. You sometimes think, I just can't do anything more. I just cannot. I have to go to sleep. But when you go to bed, you can't sleep. There's sleeplessness. So there is this reaction and contradiction in yourself, this emotional lability, where sometimes you feel good, sometimes you feel very bad, sometimes you feel like laughing, sometimes you're crying most of the time. You cannot concentrate on what's happening. You put your thing somewhere and you forget where you put it, and you spend lots of time looking for it because you forgot. So we should know what to do with it. So how do we learn to reduce all this stress? As a caregiver, you need to look after yourself to be able to look after the person you love and you're giving care to. First, you have to learn about the disease. You have to see whether what the person is doing is part of the illness or is part of their behaving especially only to you, or what you have to learn what the disease is all about and be realistic about the disease. You know what to expect from the disease and what not to expect from the disease. So be realistic about the disease, and about that we are superhuman beings, that we can do everything and we'll be able to manage all situations, but we cannot. There are some times when we cannot do it. There is limits to our own capacity. So we have to be realistic about what we are capable of doing and what we cannot do. Also, we have to accept our feelings. We have to accept that, yes, I'm angry just now. Yes, I'm feeling depressed. I just have to go away from the situation, go to another room and be realistic about your, you have to stand up, you won't do it, or resisting or shredding your diaper and throwing it away and making a mess for me to clean up. So those are realistic feelings about the situation. Also, try to share your feelings with others by always sharing things with your family members or with a good friend or with a neighbor whom you trust. Somebody whom you must have somebody in your social network. You have to develop a social network which will support you, with whom you can share your feelings, so that when you share something, they may they'll be reflect back what you're thinking or give you some sort of an advice of what to do. Again, be positive. There are times when you cannot be positive, but always try to think on the good side that, okay, this will pass. Maybe tomorrow will be different. This will not last forever. So you have to be positive and keep reinforcing yourself. Also, you have to look for humor in the situation. All situations are not very tragic. There are situations where it's quite funny sometimes, and you have to laugh with that. You have to take care of yourself first. As I said, get help. And then concentrate in the present, because you then go crazy. Coping strategies for stress. We continue. That we have to change the way you look, lighter side of it, and look at it as a job that you're doing. Take nutritional health seriously for yourself and for your loved one. Eat well. Eat nutritional food. Or in a group exercise, go for a little walk if you can leave your loved one alone at home, and practice relaxation and meditation. Try and get more sleep. Buy yourself some relief. That is important. If you can afford it, try help, hire some help. Book a massage for yourself. Get somebody to do your housework. You can come do your laundry. Get somebody to do some gardening for you, or get somebody to shovel your snow. Try to overextend yourself and build up a support system. Don't say that, yes, I can do everything. The first step in reducing stress is to try to get back control of your life. When you feel that you're helpless, you cannot control this, life is going around you and you cannot do anything, everything is slipping by you, that is when your stress level rises up, because you are feeling helpless and you cannot control anything. When you can control and get back your life, then you can start reducing your stress. What are the care receiver? Difficulty for them to perform the familiar tasks, problems with language because they may not be able to express what they are feeling, and they may say some things which does not really make too much sense, and they may be garbled, or their sentences are all mixed up. So this is a difficulty. There's disorientation of time and place. They don't know where they are or what they're doing. They misplace objects, and there's a decreased or poor judgment. They may do things which are not appropriate. So these are the problems which you will face. Other problems are the problems with abstract thinking. That means this is more towards in the early stages, when they're balancing a checkbook, they cannot do that. You ask them to write the check for their rent or the electricity or whatever, they cannot do that. Then there's changes in mood swings. There are tears, and sometimes there's anger. And there's lots of changes in moods. There's a change in personality. The person who was quite a normal person becomes confused, becomes suspicious, becomes withdrawn, and all those are changes which is difficult for you to understand. So unless you understand that this is part of the illness and this will happen as the disease progresses, you'll feel very angry. There's a loss of initiative. The person you're giving care to becomes passive, becomes apathetic, needs prompting, needs cueing, and they don't want to do things. There's no initiative for them to do. But all these signs do not appear at once, and they do not appear in all people. It appears in some people, in some times. Different stages of the disease, different types of caregiving is necessary. So it is best to get an early diagnosis. So when you get an early diagnosis, you can start a treatment plan, both for the patient, both pharmacological treatment plan and non-pharmacological. You can do what can be done as activities for this person. So you can start planning early in the disease process. You can get as much information as possible about the disease by contacting the Alzheimer's Society of Montreal or the Alzheimer Group, and they both have very good material which they can share with you. Express your feelings of anger, sadness, frustration, tell your friends and family, and share your burden. So these are the things which we talked about, and this happens in the early stages because you feel more angry and more frustrated. Explore with your doctor, explore with her doctor the clinical treatment options. Participate, if they offer you some clinical research trials, participate in that. They may not offer some immediate treatment or cure, but they will help other people in the long run. But also by going through these clinical research trials, you're in constant contact with the physician, you're constant contact with the social worker, so you get more support throughout this disease process. Plan for the future to get the legal and financial papers in order. I told you that in the beginning. And you to make sure that the mandate is made and a will is made, because after the person becomes incompetent and cannot make any decisions, it will be difficult for you. There's no mandate to do. You don't have the authority to take action. You need to have some authority. Choose somebody to make a mandate, somebody from the person is comfortable with, wish to make the financial and healthcare decisions when they are not capable of, and get them to express their wishes beforehand so you know what their wishes are, so that they write them down. And you can develop a massive environment, which I've said. So Alzheimer not only causes loss of memory, but also for changes in behavior. Some people may become aggressive, frightened, frustrated. They do not remember where they are, place their objects. They become paranoid, thinking somebody stole from them. They put it somewhere and they cannot find it at all. It sometimes we search the whole house and it's in a place where they put it where nobody could imagine where it could go. But still they put it there. And they cannot understand what's happening around them, and they cannot express them. Finishes. And language, as we said, is not only just written, spoken language, but it's also be reading language. They may not be able to read the newspapers, which they used to do before. They may not be able to sign or write whatever they used to do before. There are some strategies for these common behaviors. When they become very restless, when they're moving around in the house, they keep opening the doors or going from here to defeating anybody, they're not harming anybody, not doing any this things. Repeated action. If the behavior does not bother or do nothing, distract them with simple activities. If they keep repeating the same thing, asking the same question again and again, doing the same action, try to distract them by doing other simple activities. Change the subject, talk of something else, but all the time, remember to stay calm. The more agitated you become, the more agitated the person becomes, because your behavior is reflected. They reflect your behavior. If you find that somebody has become suspicious, provide comfort. Do not argue or try to reason, because that's not going to take, you're not going to convince them. And do not take the accusations which they're making person is suspicious. If you find that your person is wandering about, reassure the patient and them. All the patients would want to stand near the door and they wanted to go out also. So we tried to take them away at that time, or ask the staff to leave from another entrance, exit, and not from the door, which is for the entrance. And to home. Sometimes they would say, oh, my children are coming home, it's 4 o'clock. And wondering, sometimes you may see them on the road, so please try to bring them back. You may find that the person has become aggressive, so how are you going to manage that aggression? Try to be yourself. Try to be calm and reassuring. If you become more aggressive, if you don't do that, if your voice is higher up, you raise your voice, they will reflect on that. Give space to cool down. Take them away to another place. If somebody is annoying them, take them away, distract them, and look for immediate cause. To see what is causing them, what is aggression. Sometimes they're very wet when they're sitting. They may be, the diapers may be needs changing. They may be hungry. They may be cold. You see what is causing this aggression and this behavior. If the person, sometimes you think that, why should I keep trying to communicate with them when they do not understand what I'm saying and I don't understand what they're saying? But you have to remember that the person with the disease is still the same person. He needs to be looked after with respect and dignity. The person has not changed, but the behavior, the brain doesn't function as it. But the person can still respond to the touch, to smile, and to acknowledgement, because your touch is more familiar to them than a stranger's touch. So your touch, your smile, your acknowledgement will cool and soothe them down. So do respond, do try to give them non-verbal communication if there's no verbal communication. Emotions and feelings are remembered much longer than memory is no longer functioning. They may not remember things, but they can remember the emotions which went with it. They can remember the feelings which went with it, and communicate with the person with the disease with gentle emotions. The more angry you get, the more agitated you get, it will reflect on them. They will respond with the same type of behavior. The more gentle you are, more soothing you are, you just hold their hands, do nothing, then it'll calm them down. Listening. So there's a two-way communication. Communications can be verbal from the words we use. The communications can be non-verbal by the body language we use. And the communication can be paraverbal from the tone, from our pacing, from the volume of our voice, from the speed of what we do. In dementia, what happens is that the communication is affected. And this can lead to misunderstanding and mutual frustration. The person gets frustrated because he feels that I'm saying something, I'm mumbling something, and how come this lady or man is not understanding what I'm saying? And you are frustrated because you can. Because the words become more and more garbled, and thus the whole sentence does not come out. And the caregiver needs to find ways to communicate more effectively using non-verbal techniques. Just by whatever they say, you don't understand it, but if you just nod your head and say, oh yes, I see, and just say innocuous things which doesn't make any sense to either to you or to that person will think that you are understanding them. If you hold their hands and talk to them, that again will calm them down. So those are the non-verbal body language which helps to make communication more effective. Loss of communication, what causes this loss of verbal communication is difficulty finding a word. They sometimes make up words, they repeat the same word or the phrase again and again. Difficulty organizing words in a logical sentence. They may say one word and this is another jumbled word. They use cursing or offensive language, and generally they revert back to the first language. If they had say Ukrainian as their first language or Russian as their first language, and they're living in Canada for many years and now they're functioning in English, but they start beginning to lose English and they go back to the original language. But you don't know that original language. We had Chinese clients, and we don't speak Chinese. So we asked the relatives to write some words which we can communicate with them. We can say those very simple words, and that would help. So there are different communication challenges. In the early stages, there's a difficulty understanding humor. They may not understanding any joke you made. They may not be able to laugh. And they need more time to respond to them. There's a train of thought. In the middle stages, there's trouble understanding everyday conversation. They may ask to repeat the same sentence again. They have difficulty in reading and understanding. They may read the same line again and again in the newspaper. There's difficulty to interpret facial expressions. Like when you say yes or no, but you just nod. But that person may not understand what that nod is. They may don't know whether there's a yes or a no. There is a difficulty in finishing a sentence. Speaks in a vague and rambling sentences. So that happens in the middle stages. And the late stages, there's loss of all capacity for recognizable speech. And although words and phrases may occasionally be muttered, they make no sense. So at this stage, you have to have more non-verbal communication, becomes increasingly more important. And it's important to be able, because they cannot understand any words. They lose their ability to recognize speech. The words or phrases may occasionally be muttered. Language does not make any sense to others, what they're saying. Sometimes much later on, towards the end, they become totally mute. People in this late stage experience the world through their own senses, what they perceive it, what they understand it. So what they can do, what they do understand is a touch. Holding hands, massaging gently the legs and the feet. That gives them, because we all want a human touch. And just how we in COVID, they miss a kiss or they miss something else. So those are the things which are very fundamental to our being. We need a touch. We need a smell. We need to smell something. Smell of a favorite perfume. Smell of a flower may bring back happy memories. You ask the loved one as to what has been the favorite flower, or what is the favorite food, and bring those food for them, so that the smell of the in our hospital, where they smell the aroma of the baking, the aroma of the apples, would inside bring back some memories and bring back some smile on their face. Vision is also good. They can see, so you can have some videos of natural scenes or calming sounds or their family pictures, which they can relate. And in a rock on what I was saying, but I would just hold the person's hand and he would keep talking and I would keep nodding my head. And that was all we did. And we spent an hour like that. And I would do my work with the other hand. So the strategies for caregivers, individuals have this. You have to remember that the people with dementia have good days and bad days, just like all of us. And that depends on their quality of sleep, their stress level, and your stress level and your sleep. Be respectful, sensitive, with ongoing communications. No matter what stage of dementia is, the person is confused. Learn as much as you can about the disease, its progression, and how it affects the person. It will help you. Where is it? It will help you to be prepared. If you know what the disease is and what to expect the next stage, what is to be coming on, you'll be able to be more prepared. The person maintains a course. The person may be quite non-verbal, the person may be aggressive, but still the person, let's not lose the core personality, the core self can be reached. Somehow or the other, you have to try to reach that person, because there is a person inside. In spite of all the disease, there is a person there. What the person who says or does behaves has meaning, only we do not understand it. Focus on the abilities and skills which are still remaining. Whatever little things is remaining, try to bring out the positive, reassuring and be positive. New activities can be can be confusing. So use familiar things to create a sense of comfort and reassurance. Most important thing with people with dementia is because the whole world around them is changing. The whole world where they're living, with the room they are in, makes no sense to them. So we have to try to reassure them and give them comfort and positive feeling that what is happening is now and here. And upbeat, even though you don't feel upbeat and positive in yourself, try to do that, because you will feel better and the person you're giving care to will feel better. And as the disease progresses, the person's reception becomes, however, it is their reality. What they say, what they feel is their reality. We should not try to correct them and say, no, 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 this is not it. This is the right way. If they say this is the right way, okay, this is the right, let it be. Avoid contradicting, because you will not win. Do not try to convince them that what they're saying is not true. Trying to bring them to your reality will cause frustration and make things do not try to correct them to bring back to your reality. Okay, I think this is what we've done before. So communication tips for caregivers: reduce distractions, try to gain the attention of the person in the different stages. Be aware of your own tone of voice. Try to keep calm and soothing and reassuring. Be aware of your own body language. If you are big, agitated and fierce, and the person will react to that. Be patient, be clear and concise in what you're giving instructions. Don't give long instructions, give 2-word instructions, 3-word instructions, so they understand what you're being saying. Be respectful, listen carefully, encourage humor and laughter. Where is it? Yeah, and respect sadness. If sometimes a person feels sad and they will ask you that, am I going to die? Is it going to become bad? Don't give them bad. No, 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 everything is going to be all right. Tell them, yes, this is an illness. It will become a little worse, but we'll go through it together. Don't worry, we'll manage it together. And then you account for their hearing and their visual loss. If they're having hearing loss, see if they can be managed by giving a hearing aid. See if there's a visual loss, if their glasses needs to be changed, or something to be done which could improve them. Now, is there any medications to help? Yes, there are 4 medications now, but they do not reverse the disease. They only slow the progression. It's not that by giving these 4 medications, they're going back to the normal stage. That's not going to happen. It is only going to slow. If they were going to go down within, say, 6 months, they'll go down within 12 months. So that's how it is going to be. So it'll slow down. And it'll give you a better quality of life for a few more years, so that you'll be able to deal with the situation a little bit better. So, Caitlin, can you?
Yeah, so thank you so much, Dr. Destor, for that fantastic presentation. Does anybody have any questions for Dr. Destor? Are there any questions for Dr. Destor?
So how you are? I think you need to unmute the people.
Yeah, so everyone, if anybody has any questions that you'd like to ask directly to Dr. Destor, you can unmute yourself, or you can write them down in the chat box.
Can you hear me, Martin Payne?
Yes.
Yes.
All right. I had my mute button on, and I'm sorry. I'm 85 years of age, and I'm the caregiver. My wife is 83, and she's got well, I'll let you tell me what she's got. Not Alzheimer's, but aphasia. So her memory is ability to enunciate words and describe what she wants. And it's very, very frustrating for her. and it's extremely frustrating for me. And I emphasize once again, I'm 85 years of age. Uh, what is the relief that I can get now and again? I don't sleep very well anymore, and I just feel very, very tired. And there's
Is she with aphasia? Is it just verbal, or can she write? Can she write and communicate, or all sorts of communications is difficult?
it's vocal. She can communicate vocally, but she forgets her words. So I have to give her a key word. I know the subject, or if I don't, I ask her, what is the subject? And if she can communicate with that, then I say, tell me. So maybe there is no, I don't know. Aphasia,
Is
I
she?
don't know whether aphasia has a society. My daughter is a psychologist in Los Angeles, and uh, she gave it that name, aphasia, and I looked it up, and it is so. My wife's memory sometimes is better than mine, but her ability to express her words and sentences is garbled and is confusing.
There is this. There's a message in the chat box saying that there is a aphasia society. So maybe you can contact the Alzheimer group and they can help you, because the message is from them.
Okay. Thank you.
You're welcome. I hope your situation improves.
I hope so too.
So if you go to the chat box, there is a link to the Aphasia Society.
The link to what? I'm sorry?
To the Aphasia Society.
Oh, there is an aphasia society. Okay.
Yes.
I'll look it up. Thank you.
Perfect. We do have a question down in the chat box for you, Dr. Destor.
Yeah, it says my mother has mild dementia and hearing loss. I lost the other part of the chat.
Oh, okay. So it says, when she doesn't seem to hear, my wife raises her voice and my mother-in-law reacts to the raised voice. Is there a happy medium?
Yes, I think raising your voice doesn't, we think that by raising our voice and by speaking louder, the person is going to able to hear us more. But that is not women. Keep our voices low. In our ear, and we cannot hear when we raise our voice much louder and we go louder, the sound, the articulation becomes less. So it's much better to change the wordings instead of repeating the same sentence again and again in a louder voice. If you lower your voice and change the construction of your sentence, the person will be able to understand you better. In the end, if nothing works, you should write down what you want and show it to the person so they can read it.
Perfect. Are there any other questions for Dr. Destor? All right. Well, thank you so much, Dr. Destor, for that fantastic presentation. As you see in the chat box, everyone really loved it. They loved the information that you gave them. As always, we do have all of our links down in the chat box to our Eventbrite page, as we have added new dates for December as well for the end of January. We also have the link for a brief survey. We would love to have some feedback about today's event or any other Brainy Boomer event that you've attended. And in case that you've missed an event, we've put our YouTube link in the chat box as well, in case you'd like to see an event you've missed or go back and get some more information on an event that you've attended. So thank you so much one more time, and I hope you guys all have a great day.
Thank you.